coming to outcomes, when assessing the value of BGX guided prescribing, there's often a preference for well-established outcomes such as survival or time to event measures. What are the potential drawbacks of using solely clinical outcomes? And under what circumstances might the use of surrogate outcomes be more appropriate?
So if you look at clinical trials overall, and particularly the phase 3 trials, then you need hard clinical endpoints. And in oncology drugs, people will use progression-free survival, duration response, overall survival, and other measures like that. When you're looking at, for example, cancer drugs. When you look at more earlier trials, phase 2B, etc., you can often have surrogate measures which identify the potential of the clinical outcome in the future and so on. So it really does depend on what you're looking at, what particular drug you're looking at, what genetic polymorphism you're looking at, what outcomes and phenotypes you're looking at, and so on, from that to decide what is the best way to be able to do this. And so if we go back to the previous example, to tamoxifen, it would have been, for most people, it would be extremely costly to do a trial with 7-year follow-up of every patient to be able to get that clinical outcome measure. Hence, people have used observational data, retrospective data, to be able to show the positive effect of tamoxifen in cytochrome P452D6 genotype groups and so on. So I think it does depend on the drug and exactly in terms of what final outcome you're looking at.
Indeed, I did a very quick search last night, and the only prospective trial looking at the tamoxifen and genotyping effect was actually 5 years duration, which I don't think is enough, because usually it's after 5 years, particularly with early cancer age.
So it really does depend on the phenotype and the outcome that you're looking at.